I want you to do something for me. Just picture the start of your day.
Okay.
It's a Tuesday, maybe. You got your coffee, you're rubbing the sleep out of your eyes, and you unlock your phone. You check the news, and there it is.
I think I know where this is going.
You scroll past the weather, past the sports, and you hit the headline. You know the one I'm talking about.
Okay.
It's some variation of healthcare system on the brink of collapse.
Or exploding costs threaten future of care.
Yeah, exactly.
It is the background radiation of modern life. It's always there, humming in the distance.
It really is. It's this constant low-level dread. We are told over and over again that we are living too long. We are getting too old.
Too sick.
We are getting too sick, and the treatments, they're getting too expensive. The narrative is that the healthcare system is this runaway train barreling toward a cliff, and we are all just passengers just waiting for the crash.
And there's nothing you can do about it.
Nothing. It feels inevitable. It feels like a force of nature, like
A hurricane or an earthquake.
Exactly. You can't stop it. You can only brace for impact.
It's a narrative of scarcity. That's what it is at its core. It tells us that the pie is shrinking, or rather that our appetite is growing so fast that the pie can never, ever be big enough.
Right.
It frames healthcare as a financial black hole that will eventually swallow the entire economy if we don't make hard choices.
Hard choices. And that's usually code for cutting services, right?
Almost always.
But, and this is why I was so excited to dig into this stack of research today, what if that entire story is, well, what if it's wrong? What if the unsolvable crisis isn't actually about a lack of money? What if the claim that healthcare is unaffordable is a myth built on a very specific and maybe even manipulative way of looking at the numbers?
That is the aha moment we are chasing today.
It really is.
We are going to deconstruct one of the most persistent beliefs in our society. And we're basing this deep dive on a truly illuminating conversation between Jonah Walk and a woman named Marjet Veldhuis. And Veldhuis is the perfect guide for this because she's a bit of a double agent.
I love her backstory. It's almost cinematic. She didn't start out as a policy wonk or a bureaucrat in a high-rise office. She started, in the mud. She was a nurse.
She trained in Groningen, up in the north of the Netherlands. She worked in the emergency room. She worked in ambulances on the streets of Amsterdam.
Wow.
She talks about starting her career from the heart. She wasn't there for the status or the pension. She wanted to be the hands, the bedside. She wanted to be the person stopping the bleeding, holding the hand, calming the terrified patient. That was her identity. She was in care.
In care. Okay, let's hold on to that phrase because it's going to be crucial.
Very.
But then her career hit a wall, a physical wall. She developed a severe latex allergy.
And we have to remember, this was years ago. Today, you have nitrile gloves everywhere. It's not a big deal.
Yeah.
Back then, latex was the atmosphere of a hospital.
Oh, it's everything.
It was in the gloves, the tubing, the equipment. It wasn't just a rash. It was a severe systemic reaction. It became an occupational disease. She physically could not enter the building without risking her own health.
Which is just tragic. You have a calling, you have the skills, but your body literally rejects the workplace. It forced her out of clinical work entirely. But, and this is the twist, she didn't leave the sector. She didn't go sell real estate. She decided to figure out how the machine worked from the other side.
She retrained. She went to Maastricht University and studied health policy and management. She learned economics. She learned public administration.
So she learned the language of the suits.
She learned the language of the suits. And then she went to work for them. She worked for health insurers. She worked for municipalities. She sat on advisory boards like the Care Institute.
So she goes from checking vitals in a speeding ambulance to sitting in boardrooms discussing multi-million euro budgets.
It's an incredible journey.
She has inhabited two completely opposing worlds.
Precisely. She knows the system from the bedside, which she calls in care. And she knows it from the boardroom, which she calls at care.
In care and at care.
Okay.
And because she speaks both languages, the language of suffering and the language of spreadsheets, she realized something profound. The story the people at the top tell themselves about why the system is failing. It just doesn't match the reality of the math.
She wrote a book called Holy Houses. In Dutch, Heilige Huisjes, which essentially means sacred cows.
Yeah, that's a good translation.
And her mission, which is our mission for the next hour, is to slaughter those sacred cows. We are going to look at why we seem to have more managers than nurses, why throwing billions of euros at the system doesn't seem to help the patient,
Yeah.
and, most importantly, her actually quite radical common sense solutions to fix it.
And we have to start with the biggest, fattest, sacred cow of them all.
The money.
The money. The money myth. Okay, let's unpack this, because I feel like every time I turn on the news, the headline is screaming one word: exploding. Healthcare costs are exploding. It implies violence. It implies shrapnel. It implies that if we don't do something, the budget is going to blow up the country.
The very effective fear tactic.
Yeah.
But Veldhuis brings a bucket of cold water to that fire. She points to something she calls the 10% rule.
The 10% rule. Okay.
If you look at the actual statistics, not the headlines, but the data from the Ministry of Finance and the National Statistics Agencies, healthcare costs in the Netherlands have remained remarkably stable for years.
Stable? Really? That seems counterintuitive.
It does, but the numbers don't lie. For a long time, the cost of healthcare has hovered roughly around 10% of the gross domestic product, or GDP.
Wait, only 10%? The way politicians talk, I assumed it was like half the budget.
It feels that way, doesn't it?
Yeah.
But the slice of the national pie that we dedicate to keeping people alive and healthy hasn't fundamentally changed size.
Wow.
Now, to be fair, there was a spike during the COVID-19 pandemic.
Well, sure. We shut down the world and mobilized every resource we had. That's an outlier. Of course, that's going to cost more.
Exactly. That was a global emergency. But if you smooth that out and look at the trend line, it's flat. We aren't actually spending a larger share of our collective wealth on care than we were years ago.
Okay, so if the slice of the pie is the same size, why does it feel so much more expensive? Why do I keep hearing that we need to save money? Why are my premiums going up?
This is where Veldhuis explains the inflation trick. It's the difference between hard numbers and percentages.
Okay.
Let's use a simple analogy. Think about a loaf of bread or a bouquet of flowers.
Yeah.
20 years ago, what did a loaf of bread cost?
I don't know. Maybe €1. $1, something like that.
And today?
Probably 3 or 4. Easy.
Right. Everything gets more expensive over time. That is inflation. The raw number of euros or dollars you have to hand over at the register increases.
Okay, I'm with you.
So if the national healthcare budget was $50 billion 20 years ago, it might be $100 billion today.
So the number has doubled. The hard number is huge.
Exactly. And if you are a politician looking to justify cuts or a newspaper editor looking for clicks, you point at that raw number, 100 billion, and you scream, "Look, it's doubled. It's unsustainable. We are hemorrhaging money."
But you're ignoring the fact that the economy, the GDP, has also grown, probably doubled too. Our collective salary has gone up.
Precisely. Relative to what the country earns, the cost is the same. It's a stable burden. But by focusing on the raw currency amount, the hard numbers, they create a narrative of doom.
Right.
It justifies the call for efficiency. It justifies the need to squeeze the nurses and the doctors.
That is such a crucial distinction. I mean, it changes the emotional tone of the debate entirely.
Completely.
It goes from we are going bankrupt to we are maintaining a steady investment. But, and here's the big question that drives me crazy. If the pot of money is stable and 10% of a wealthy nation's GDP is a massive amount of money, why does the system feel so starved?
So why are there waiting lists? Why are nurses burning out? Why does every hospital feel like it's operating on a skeleton crew?
Exactly. If the money is there, where is it hiding?
That is the pivotal question of this entire deep dive. Veldhuis argues the problem isn't the total amount in the pot.
Right.
It's the distribution inside the system. We know the 100 billion goes into the healthcare machine, but what happens inside, it enters a black box.
A black box.
And this leads us to Veldhuis's central framework, the lens through which she sees the entire crisis.
This is the distinction between in care and at care.
Correct. And we need to define these terms rigorously because everything else we discuss hangs on this distinction.
Let's do it. In care, in disorg. What does that mean exactly?
This is the primary process. This is the reason the system exists. It is the doctor holding the scalpel, the nurse washing the elderly patient.
The hands-on work.
Yes. The physical therapist helping a stroke victim walk again. The assistant drawing blood. It is anyone whose hands are directly involved in making a patient better or caring for them.
The people we clapped for. The people we called heroes during the pandemic.
The doers. The people who actually care.
Okay. And then you have at Karen and disorg.
This is the secondary process. This is everything organizing the care. The management, the board of directors, the quality control officers,
The bureaucracy.
the HR departments, the communication managers, the policymakers, the insurance bureaucracy. They're working at the healthcare system, not in it.
They are the overhead, the structure around the care.
Right. And Veldhuis is careful here. She isn't saying we don't need any management. Of course not. You need someone to pay the bills, someone to order the bandages, someone to ensure the lights stay on.
Sure, some organization is necessary.
But she describes an aggressive, tumor-like expansion of this layer over the last few decades.
She contrasts it with the past, right? How did hospitals used to be run?
It's a stark difference. If you go back 30 or 40 years, a hospital might have had a medical director, usually a senior doctor, who still saw patients.
Still practicing?
Yes, still practicing, and a head nurse. That was the administration. Maybe a few clerks to the paperwork. That was it.
And now?
Now, look at an organogram of a modern healthcare institution. It's a labyrinth. You have cluster managers, functional directors, strategic advisors, compliance officers, diversity coordinators, brand managers, innovation leads. It goes on and on.
And here is the kicker that really stood out to me in the source material. We are obsessed with measuring the in-care people.
Obsessed. We track everything. We know exactly how many minutes a home care nurse is allowed to spend putting on compression stockings.
We've timed it down to the second.
We measure the production of a surgeon. We have dashboards and KPIs for every second of a nurse's shift. The in-care layer is scrutinized, timed, and squeezed.
But do we measure the at-care layer?
No. We have almost no data on them. It is essentially unmeasured overhead.
Wow.
Veldhuis points out that while the total budget is fixed, that 10% slice, the at-care layer keeps expanding its share. So logically, it's a zero-sum game. If the pie is a fixed size and the managers are taking a bigger slice,
the nurses and patients get a smaller slice. There's nowhere else for it to come from.
Exactly. And when those inevitable calls for budget cuts come, driven by the money myth we talked about, where do those cuts fall? Do they fire the compliance officers? Do they merge the communication departments?
I'm guessing no. Cutting in your own flesh hurts, as Veldhuis says.
Precisely. The at-care layer is in charge of the budget.
Yeah.
They aren't going to fire themselves. So they look at the in-care layer. They say, we need to work more efficiently. They raise the patient's deductible. They reduce the staff-to-patient ratio. They squeeze the primary process to pay for the secondary process.
It's perverse. You starve the thing that actually provides value to feed the thing that just watches the value being provided.
And the irony goes deeper. Veldhuis points out that the at-care layer justifies its existence by creating work for the in-care layer.
This is the bureaucracy trap. Explain that.
Think about it from the perspective of a quality manager. Your job is to manage quality.
Yep.
How do you prove you are doing your job? You can't just trust the nurse.
No, you need a paper trail.
You need proof. You need data. So you create a checklist. You create a new protocol. You create a reporting requirement.
So now the nurse, who is already short-staffed because the budget went to hire the quality manager, has to spend 20 minutes of her shift filling out a form to prove to the quality manager that she did her job.
Which is 20 minutes she isn't spending with the patient.
Right.
Which arguably lowers the quality of care, which causes the quality manager to say, oh no, quality is slipping. We need another protocol. We need another form.
It's a doom loop. The bureaucracy feeds on the time and energy of the care providers. It extracts value from the bedside and turns it into spreadsheets.
And this connects directly to the staffing shortage. Because that's the other big headline we always see. We just don't have enough people.
The labor market is too tight. Young people don't want to work.
All of that. But Veldhuis calls this a created staffing shortage. That is a bold claim. She's saying it's not just nature. It's not just demographics.
That's a huge accusation, really.
It is, and she is very firm on this. She argues that professionals aren't leaving the industry just because of the pay, though better pay would certainly help, or just because of the aging population. They're leaving because the work has been made impossible to perform with any sense of satisfaction.
She breaks this down into a few categories. Let's talk about fragmentation. This sounds like a factory term.
It is, and that's the problem. Imagine you are a nurse. You went into the profession to care for people holistically. You see Mrs. Jansen. She's anxious, she's in pain, she needs her medication, and she needs a wash.
Okay.
In a functional system, you go in, you soothe her, you wash her, you give the meds. You are a professional giving care to a human being.
You treat the person, not the symptoms.
But in the at-care managed system, that job has been chopped up into tiny protocol-driven products. Product A, administer medication. Product B, wound care. Product C, hygiene.
It becomes an assembly line.
Yes, and often Different people do different tasks because it's more efficient on a spreadsheet to have a lower-paid worker do the washing and a higher-paid worker do the meds. Or the nurse is just running a script. I am here to perform task 4B.
It strips the autonomy out of the job. You aren't a caregiver, you're a task executor.
And people hate that. Nobody wants to be a robot, especially not people who are driven by empathy.
No, of course not. That's why they got into it in the first place.
Exactly. It causes moral injury. Then you add the administrative burden we talked about. Veldhuis notes that all this at-care bureaucracy steals huge chunks of the day.
And then there's digitalization. Oh man, this one resonates with me. We're always sold new tech as a time saver. Just use this iPad, it'll make everything faster.
It's seamless, it's integrated.
Yeah.
But in the reality of healthcare, often it does the opposite.
How sad.
Veldhuis points out that these systems are designed by the at-care layer for the at-care layer.
What does that mean?
It means the system is hungry for data. It wants stats for the managers to put in their reports. So the nurse becomes a data entry clerk. She has to click through 12 screens to register a simple procedure so that the billing department and the quality department get their numbers.
Right. It's not designed for the user, it's designed for the manager.
Precisely. And if the Wi-Fi is down or the battery dies or the interface is clunky, which it almost always is, it increases the workload rather than reducing it.
So the work becomes less satisfying, more bureaucratic, and more stressful. So people quit. They leave for jobs where they are treated like adults.
And here is the vicious cycle. As staff leave, the at-care layer looks at the problem. But because they are managers, they look for a management solution. They see a shortage. So what do? Do they make the job better? Do they strip away the paperwork?
I'm guessing no.
No. They hire more people around the job. Veldhuis has mentioned some specific titles she's seen that sounded absurd. Mantelzorg brokers, academic coordinators.
Care logisticians, a Mantelzorg broker. I have to stop you there. For our international listeners, Mantelzorg is informal care-like, a daughter taking care of her sick mother.
Correct. It's family caregiving.
So instead of hiring a nurse to help the sick mother, they hire a broker to coordinate the daughter to help the sick mother.
Precisely. They are trying to solve a shortage of doers by hiring more thinkers and organizers. They create roles that are about care, but are not care.
It's like trying to fix a leak in a boat by hiring a consultant to analyze the water flow rather than just getting someone to plug the hole.
That is a perfect analogy. You have 5 people staring at the hole, analyzing the rate of ingress, writing reports on dampness levels, and nobody is holding a bucket.
And meanwhile, the one guy with the bucket is drowning, and the consultants are yelling at him to bail faster while filling out a form about his bailing technique.
It's tragic comedy. But it speaks to a deeper issue Veldhuis identifies: the clash of cultures, the difference between the reality of care and the models used to manage it.
This is the ivory tower section of our investigation. Veldhuis argues that the people making the rules, the public administrators, the economists, the managers, they literally cannot understand the reality of the hospital floor.
She calls it the frequency illusion. That's a cognitive bias, sometimes called the Bader-Meinhof phenomenon. But here she applies it to professional training.
So it's about what you're trained to see.
Exactly. If you are trained in business administration, your brain is wired to look for business administration solutions. When you look at a hospital, you don't see suffering and healing. You see a process. You see inputs and outputs.
You see a factory.
And you try to optimize it like a factory. But Veldhuis points out that some things in healthcare just can't be solved like a business problem. You can't optimize grief. You can't efficiency your way out of chronic illness. Sometimes care is just being there, waiting, comforting.
And that doesn't fit in a spreadsheet.
It looks like wasted time to an efficiency consultant. Why did that nurse spend 20 minutes just holding the patient's hand? That's zero production. Eliminate that variance.
But to the patient, that was the most important 20 minutes of the day, maybe the most important 20 minutes of their life.
Exactly. There's a fundamental disconnect. The management mindset is, problem leads to solution. The healthcare reality is, some problems, like death or decline, cannot be solved, only cared for.
And when you try to force one into the other,
you get broken systems and broken people.
And they speak different languages. This part cracked me up, but it's also kind of horrifying. The at-care world speaks legitimation language, Congress language.
Vague language. It sanitizes the reality. Veldhuis gives a great example. A nurse might say, "We are tired. We're crying in the break room. We can't keep the patient safe anymore. We are drowning."
That's raw human truth. It demands action. It screams for help.
But by the time that message filters up the chain of command to the boardroom, it has been translated. It becomes, we are facing labor market challenges, and capacity optimization issues require strategic realignment.
It strips the emotion out of it. It makes it safe. It makes it something you could put in a report.
It makes it abstract. Challenges are things you put in a PowerPoint.
Yeah.
Crying nurses are things you have to feel. The language allows the policymakers to distance themselves from the suffering their policies cause. It acts as a shield.
There was one anecdote she shared that I think perfectly encapsulates this arrogance. It was about a politician during COVID. Do you remember this?
Vividly, it's almost shocking. Veldhuis recounts a politician saying that if people had just behaved according to the IVM models, that's the Dutch National Institute for Public Health, then the models would have been correct.
That is wild. The model was right. The reality was wrong.
It perfectly illustrates the mindset of the at-care layer. They believe the map is more real than the territory. If the patient or the virus or the population doesn't fit the spreadsheet, then the people are the problem, not the spreadsheet.
It's gaslighting on a national scale. You're not sick correctly. You're not behaving according to our projection.
And this mindset permeates everything, especially the financial side. Which brings us to the black box of insurance.
Right. In the Netherlands, we have this weird hybrid system. It's not fully public, not fully private.
We do. The money comes from the public.
Right.
Taxes and mandatory premiums, you have to pay it. But the organizations managing it, the health insurers, are private companies.
And Veldhuis highlights the friction there. They receive a fixed income, essentially, guaranteed public money, but they operate as private entities, and she calls them a black box.
Because we put the money in, but there is very little transparency on how much of that money is spent on their own internal bureaucracy versus actual care payments. How much goes to their marketing, their massive glass office buildings, their executive salaries.
Yeah.
We just don't know.
And she notes a loss of medical expertise there, too. It used to be that if you dealt with an insurer, there might be a medical doctor reviewing the case, someone who understood that, no, you can't just send this patient home, they will die.
Now, it's a call center or an outsourced line. Veldhuis says if you call for care authorization, you reach someone who asks for your big registration number, your professional ID, not the patient's story.
So they're just checking boxes.
They're checking codes against a database. Does code 402 match diagnosis Y?
It's dehumanizing.
It reduces the patient to a number and the doctor to a vendor. And because these companies have a guaranteed inflow stream from the government via the Risk Equalization Fund, there's a lack of accountability. An oil company that gets too bloated goes bankrupt because customers leave.
Yeah.
But you can't really leave the system.
You're trapped. So let's recap the bleakness before we get to the hope.
Okay, let's...
We have a stable pot of money being drained by an expanding management layer. We have staff leaving because their jobs are micromanaged by people who don't understand the work.
A language barrier between the bosses and the workers.
Right. And we have an insurance industry that operates like a black box.
It sounds overwhelmingly broken.
It does. But Veldhuis is not just a critic. She is a builder. She has experience in policy. She knows how the sausage is made. And she has some very specific, somewhat radical solutions.
She does. And I love that she doesn't just propose more money. Because we've established that's not the core problem. She proposes structural change.
Let's talk about the broom. This is her fantasy, right?
Yes. She jokes, but she's serious. That if she were the Secretary General, the highest civil servant in the ministry, her first act would be to buy every broom in the province of Friesland, where she lives.
Why brooms? What's the symbolism?
She would put one in every office at the ministry. A physical broom. Not to hit anyone, obviously, but as a reminder. A symbol.
A totem.
Exactly. To remind every policymaker that their job is to sweep out the excess, to clean the house. It's a call for a radical simplification of the system.
Do we need this rule, or does this need the broom?
That's it.
I love the visual. Just a broom in the corner of a meeting room staring at you while you propose another 50-page protocol. Are you sure you want to write that? The broom is watching.
It's fantastic. But her practical proposal is even more interesting. She calls for a moratorium.
A pause button.
A complete halt on new rules. For 1 year. No new laws, no new regulations, no new protocols. Stop the machine.
Cold turkey.
Cold turkey.
What's the goal there? Just to catch your breath?
Partially. But primarily to force the bureaucrats and policymakers to actually look at what they have already created. Right now, everyone is so busy tweaking their little part of the chain, adding a rule here, changing a form there, that no one overlooks the whole system.
They don't see the forest for the trees?
Not at all. They don't realize that pulling a lever in Department A breaks something in Department B. It's like a hoarder's house. Everyone keeps bringing in new furniture, but no one ever throws anything out. Eventually, you can't walk to the kitchen.
Right.
A moratorium would force an overview. It would force them to see the tangled web they've woven.
And once they start building again, she has a specific methodology she wants to use. Sociocracy. Now, I've heard of democracy, obviously. What is sociocracy in this context?
It's a governance model. The core principle Veldhuis advocates for is that policy and execution must be combined. You cannot have a group that only thinks and a group that only does.
No more ivory tower.
No. Her proposal is no policymaker makes a rule without understanding its execution. You pair every bureaucrat with a content expert, a nurse, a doctor, a specialist.
A buddy system for the government. I like that.
Exactly. And here's the key. If the in-care person, the expert, says this won't work in reality, then the policy does not pass.
That shifts the power dynamic completely. It gives the people doing the work a veto over the people designing the work.
Which is how you prevent those absurd checklists and data entry requirements. If you had to sit next to a nurse while they tried to use your new time-saving app and you watched them struggle for 20 minutes, you wouldn't launch the app.
No, you'd be too embarrassed.
Sociocracy enforces that feedback loop.
It sounds so common sense, yet it would be a revolution in how government works. No regulation without implementation.
It would realign the system around its purpose. Care.
But revolutions require courage, and Veldhuis touches on something very dark in the source material.
The culture of fear.
Yes. This is the barrier to change. Veldhuis admits that speaking out has cost her. She has lost work. She has been uninvited from media appearances because her story is inconvenient. It upsets the at-care narrative.
And it's not just her. She talks about fear at every level.
Oh, yeah. Nurses fear losing their contracts if they complain, especially with so many on temporary or flex contracts.
Of course. It's precarious.
Patients fear being denied care or being labeled difficult if they question the process. Families fear that if they speak up for their elderly parents, the care home might retaliate or the quality of care might drop.
That is terrifying. A healthcare system where everyone is afraid to speak the truth, it keeps the dysfunction in place. If no one speaks up, the at-care layer can keep pretending everything is fine or that the problems are just external factors like aging.
So how do we break it? Veldhuis gives advice to the healthcare worker, and it's basically a call for civil disobedience.
It really is. She says, find buddies. Don't do it alone. If you are one nurse refusing to fill out a useless form, you are a problem employee. You are insubordinate.
You can be picked off and fired?
Exactly.
But if the whole ward does it?
If the entire team says, we are not doing this administrative task anymore because it hurts our patients, you are a movement. You are a union of professionals.
Strength in numbers.
She advocates for a collective refusal of administrative tasks that do not help the patient. She points out that the system relies entirely on the compliance of the in-care workers. The managers can write all the rules they want, but if the nurses stop validating those rules, the rules lose their power.
It's a powerful thought. The system only works because the people at the bottom hold it up. If they shrug, the at-care layer topples.
And despite the heavy topic, Veldhuis is optimistic. She believes the breaking point is near. She thinks that once the in-care workers and the patients align, realizing they are on the same side against the bureaucracy, the system can be flipped.
It's a hopeful note to end on. It's not just the system is broken, but we have the power to fix it if we stop playing by their rules.
Precisely.
So let's recap what we've unpacked today. We learned that the healthcare is unaffordable narrative is largely a myth based on inflation and bad framing.
Right. The percentage of GDP is stable.
We distinguish between the heroes in care, the hands at the bedside, and the exploding bureaucracy at care, the overhead that eats the budget.
We uncovered that the staffing shortage isn't just nature, it's bad design. It's fragmentation and bureaucracy driving good people away.
And we looked at the solutions, the broom, the moratorium, and sociocracy, connecting the thinkers with the doers. Veldhuis suggests that the at-care layer will never fix itself because, as she puts it, cutting in your own flesh hurts. No manager wants to fire themselves.
Which leaves the responsibility with us, with the public, and with the professionals on the floor.
So here's our final thought for you, the listener. Whether you work in healthcare or a totally different field, maybe you're in education or corporate or manufacturing, I want you to look at your daily tasks tomorrow. Really look at them.
Analyze your day.
How many of those tasks are in the work? actually creating value, helping a customer, making a product?
Mm-hmm.
And how many are at the work, reporting, coordinating, meeting about the meeting?
And the provocative question is, if you simply stopped doing the at work, would anyone actually notice?
Would the world stop? Or would things actually run smoother?
Something to think about.
Something to mull over while you're stuck in your next strategy meeting. Thanks for diving deep with us.
Until next time.